Hopefully this helps. Hold on for a minute. Okay, so these are my disclosures. Oh, what is, okay, sorry. Said hang on 1 second, so. It's not.
Can you go forward, Craig?
Okay. Oh, wait, well, this is way too much. Could you go back? You skipped a few lines.
Back.
Okay. Oh. Okay, I have control now. Okay. So for this morning, there's tons of movement disorders. I could lecture for a whole weekend, and we're not going to be finished. So I'm going to be giving you kind of a hodgepodge of things, but they're divided into themes. And at the end of this, my hope is to kind of impart some 4 key take-home messages. So the first one being is to not miss on reversible causes of movement disorders. So when sometimes there are cases that we have to get on the first visit. Now, if you miss on Parkinson's, you miss on other neurodegenerative disorders, I think that's okay. You still have a second chance, you still have a third chance. But for some of these reversible causes, you only have 1 chance, or maybe 2 at the most. And if you don't get it, usually it doesn't bode well for the patient. So one of them, the most common, is a hyperkinetic disorder. Okay, so usually the most common, one of the more common causes of a hyperkinetic movement disorder is kind of a drug-induced disorder. And you obviously would know the drug exposure. So the common one would be a dopamine receptor blocking agent, like an antipsychotic agent. And if you see something like this that occurs, it usually occurs for drug-induced movement disorders within 48 hours to at most 5 days. If it occurs later than 5 days, maybe it's not purely drug-induced anymore. So often they're dystonic. These are dystonic, retrocolic disorders. Sometimes they can have blepharospasm along with it. So this is an acute drug reaction. They were exposed to an antipsychotic agent about 24 hours prior, and this is what the result is. Often they would go to the ER, and if you're called, you're going to tell them, give IV diphenhydramine. Doesn't get controlled, IV benzodiazepine, and you send them home with a little bit of both medication. And then you can follow them up in clinic, and you'll see that they'll be much improved, but they may not be completely resolved. So study the course, continue to withhold that antipsychotic agent that caused it. Usually, it'll get better over time. Now, these next two patients have the same diagnosis. Can you guess the diagnosis? Any guesses? Other than my fellows or colleagues who know about this case? It's very common. It's one of our bread and butter in our movement disorder clinic. So they both have Parkinson's disease. And so this is levodopa-induced dyskinesias, okay? So levodopa-induced dyskinesias at the peak dose of the pharmacokinetic profile is usually choreic. So peak dose dyskinesias are usually choreic, but they can be diphasic dyskinesias at the shoulder areas when they peak, as they peak and as they wear off. When this happens, they could have a choreoballistic or even dystonic kind of profile. Here, usually it's choreic, but sometimes they just blend. They are continuously moving, like Michael J. Fox, but it changed, just the phenomenology changes a little bit from choreobalism to chorea to choreobalism to dystonia, and then back to the same cycle again. So these two patients came for evaluation of deep brain stimulation surgery, which is one of the indications for levodopa, bothersome levodopa-induced dyskinesias. Okay, so there are other reversible causes. So this one, not very common in the United States, but common in developing countries. And so this patient had rheumatic fever and has Sydenham's chorea. Oh, thank you so much, John. So the one thing I'd like to mention in Sydenham's chorea, or actually any secondary chorea, so stroke-induced chorea from a stroke in the thalamus or the parietal region, is that they're not always permanent. In fact, they're almost always not permanent. They usually subside over time. And so if you're going to give an antipsychotic agent, a dopamine blocker, VMAT2 inhibitor for these choreic disorders, always check at least once a year to see if you still need that dose or you still need that medication at all. Yeah, it usually subsides over time. So don't subject your patient for long-term treatment for chorea if it's secondary. Now, this one also has chorea, a little bit asymmetrical. Now, all choreas, it could be symmetrical, asymmetrical, but they all look the same. So there is nothing that you'll see in a chorea that says, aha, this is because of this or because of that. So you will have to do your due diligence and check for reversible causes of chorea. Almost always, even if it's asymmetrical, you have to check your sugar, blood sugar, hemoglobin A1C. You do a thyroid function test to make sure that it's not hyperthyroidism. You do a complete metabolic panel, hyperparathyroidism. All these things can give chorea. And then you can go deeper and look at rheumatological panel, antiphospholipid antibodies. You look for infectious serology if need be. If it's asymmetrical, obviously an MRI. So this is hyperthyroidism-induced chorea. So very, very reversible and not to miss. Okay. So another thing is that asymmetry really suggests, except for it doesn't rule out metabolic, so always get your thyroid function and always rule out hyperglycemia, but it almost always suggests a structural lesion. So this patient has, so very jerky, unlike the chorea, the dance-like movement that I showed in the previous video. So he has both positive jerks and a negative jerk. So a positive myoclonus and a negative myoclonus, like an asterixis, as an example. So this patient has a vascular malformation on the contralateral cortex that caused the myoclonus. And look at this. Also has the same phenomenology. Actually has myoclonic jerks as well, but looks slower, a little bit less jerky. But if you stick a needle on that muscle, it's still less than 50 milliseconds, which satisfies criterion for myoclonus. But it's segmental. It's only in that shoulder, right? So this guy has a spinal cord glioma ipsilateral to that left side. So a structural lesion for both of these for an asymmetrical myoclonic presentation. Okay. The one thing you have to be quite critical of are subacute progressive presentations. So this is the one that you may not have as many chances in getting it right from the beginning. So this is a 58-year-old woman with a progressive hyperkinetic involuntary movement. Okay. So a little bit asymmetrical, not jerky like the, slightly jerky, but more choreic. Very progressive, and it eventually went to the other side as well. So some dystonia, wide base gait, the chorea is there. And so you're going to do your workup, right? Your usual workup, and you see this. So you could see from, okay, my pointer is working. So here, you could see hyperintensity in the corpus striatum, the caudate, and the putamen. Here, this is just a diffusion-weighted imaging that shows there is no restriction, so not a stroke. This is your T1 with gadolinium that shows no enhancement, so not a tumor, and just some mineralization here and atrophy of caudate and putamenal atrophy. But this is probably the most striking one. So you have a subacute presentation, chorea getting worse, and you have this kind of hyperintensity in the basal ganglia, not a stroke, not a tumor. What's your workup? What are you going to do? You could, so your complete metabolic panel is fine, thyroid fine, no hyperglycemia. You do a CSF, 4 cells, so nothing impressive. You still get your sero-infectious kind of panel. Nothing shows up. No fungal infections, nothing. No malignant cells. Cytology is fine. You do a rheumatological panel. Nothing. Antiphospholipid body is normal, which is a good idea as well. So oligoclonal bands are fine. Slightly high protein, so there is a disruption of the blood-brain barrier, but normal glucose and no malignant cells. So the paraneoplastic workup for this woman showed up as positive for anti-CV2 or anti-CRMP5 antibodies. So the 70% of paraneoplastic choreas are anti-CV2. So you want to make sure you get this. And the most common cancer associated with CV2 antibodies is small cell lung cancer. Small cell lung cancer. And then the second most common, that's 70%, 60% of them, 60%. The 30% is from, a good answer, good guess. I would have guessed breast, but since I read about it, it's not. It's thymoma in 30%. So you could also get it in renal, you could get it in germinoma, you can get it in non-small cell lung cancer, but small cell lung cancer and thymoma would be your 1 and 2 if you're having this presentation. Okay. Another subacute, this is not bordering on chronic, but really subacute presentation. And you could see, again, you're becoming experts here now of myoclonus and chorea. So very jerky, so myoclonic. But you'll see a little bit of ataxia. You have to just trust me that he has slurred speech, and a little bit of ataxia on walking with myoclonus. Subacute progressive. Okay. So again, it's the same workup, right? The same workup. You're going to get your complete metabolic panel. You're going to get your thyroid function test, your hemoglobin, your glucose level, serological tests. Okay, you went all out, paraneoplastic. Everything's fine. You get an MRI, nothing, no enhancement like the other lady. So in this case, nothing showed up really. So the clinicians of this case dug deeper and look at, although the thyroid function test came back normal, they got antithyroxine peroxidase, and it came out high, abnormal. So they did an ultrasound. It showed thyroiditis. So this patient has Hashimoto's thyroiditis, and responded well to treatment. So yeah, of course, the more official name is steroid responsive encephalopathy with autoimmune thyroid disease or thyroiditis or something like that, which I don't care for a whole lot because not all of them are steroid responsive, and like this case, not all of them are encephalopathic. So they could just have this kind of a subacute hyperkinetic movement disorder. This next case is this, not jerky anymore, a little bit choreic, a little bit dystonic, and look at her face. There's this kind of, it's a fixed face, a rhizus sardonicus, that is from facial dystonia. Again, so chorea, dystonia, progressive, a subacute thing, not years, but just over a month or two, a little bit ataxic, and with treatment, a little bit better. Not perfect yet, but again, it's slow. Or maybe this is still just another view, I'm not sure. I don't have my cheat sheet with me, it's in the back. But again, your workup, as we kind of discussed, another case where the TSH is normal, but anti-TPO, thyroxine peroxidase, abnormally high, and ultrasound shows thyroiditis. So another case of Hashimoto's thyroiditis, this time presenting with chorea and dystonia, with a normal TFT. I'm not saying that you have to get an ultrasound in every case like this, because usually the TFTs would signify something for you to chase. But if you're stumped, you have looked at everything, CSF is normal, MRI is normal, perineoplastic rheumatological panel, they're normal, you can't figure out what's going on, and they're getting worse and worse as you see them. Maybe you could just go deeper on that thyroid, because that's the one thing that can be reversed, right? The others, if you miss them, if you miss CJD, was it really a big deal? Not as much, right? But if you miss thyroid, then it could be much. Now, when you have a subacute presentation plus encephalopathy, that you have to be even more vigilant. So this is one of my favorite patients that was shared to me during my kind of visits abroad. This one is from the island of Penang in Malaysia, 18-year-old valedictorian, and just over a span of 2 weeks, started talking less and less, became more agitated, with dizziness, headache, all these weird constitutional symptoms. So then she couldn't talk anymore, but she still had some sense that something was wrong with her, and the last thing she wrote was, "Bring me to the hospital." So she was brought to the hospital on her urging, and encephalopathic, but showing two very characteristic presentations of this disorder. So you could see this stereotypic hyperkinetic movement disorder in the mouth and in the feet. So if the mouth and feet are moving, what? Sure, but the diagnosis should clue you in. You have to do your workup, because obviously you have to check for everything infectious and get an MRI and stuff, but this should heighten your senses, like, oh my God, oral movements and feet movements, and always the same like this, in the setting of subacute progressive encephalopathy. Perfect. So NMDA. So NMDA antibodies is the correct answer for this. And almost, in the majority of cases, NMDA is perineoplastic. And so in her case, a young woman, pelvic CT shows an ovarian tumor. And then obviously you take it out. And so she is significantly better in just after a couple of weeks. And then back to her old valedictory self a few months later. So again, this is a big save by the Malaysian team. One of the earlier cases actually of NMDA, before it was even known, the orofacial and foot stereotypies, the stereotypic here, just in the setting of encephalopathy, just moving the mouth and then the feet like that. They can present with many things. You'll see it later. But when you see this, that's the first ding, 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 ding kind of Augen Bliss diagnosis. The spinal fluid, I don't remember the details of the spinal fluid. I don't have, otherwise I would be. Oh, usually, sorry. So what is positive is the serum or the CSF. The CSF, for perineoplastic ones, if you strongly suspect it, you have to get CSF as a sample. The serum should show it, but they have misses on this. So if the serum, all the serum panel is negative, but then you suspect it, especially if you see already a source, because often you would do this in tandem. You would get a PET CT or CT of the chest abdomen, and you see a spot here, and then the serum is negative, so usually we would get CSF. Yes, sir. Yes. This is exactly. So ovarian, the removal of the offending tumor, yes, for sure. This is what they did in her case. I totally agree. Okay. So, 3 cases of opsoclonus here, and 2 of the 3, the upper 2, shows satisfies opsoclonus myoclonus ataxia syndrome, OMA, because they can have opsoclonus, and sometimes with myoclonus, and sometimes with ataxia, sometimes with both. But it is a syndrome because it's not just one disorder causing this. It could be from any. So this one, when you see this chaotic eye movement, that's opsoclonus, okay? You don't have to wonder too many things. And then she has a little bit of ataxia, not as impressive, but So subacute in presentation. This time the thyroid function tests is abnormal from the beginning. So easier case of Hashimoto's thyroiditis just from the screening test. So I showed you a Hashimoto's thyroiditis that presented with myoclonus and ataxia, that presented with chorea and dystonia, that presented with opsoclonus myoclonus ataxia syndrome. You're never going to miss steroid responsive encephalopathy from thyroid antibodies. Okay, so this one also with some chaotic eye movements, but presented with a fever and cough and some difficulty with sense of smell back in 2022, 2021. So diagnosis, so COVID. So had SARS. So opsoclonus myoclonus ataxia syndrome present from COVID. OMA syndrome has also been described in Lyme disease, another differential that you could get. But I mean, I guess when you look at this, you have to get for all, but the ones this is described in COVID. Now, the next just opsoclonus. This is not OMA, but you saw the opsoclonus there a while ago, and a little bit of stereotypic facial disorders. The workup here, he has non-ketotic hyperglycemia. And so with treatment, obviously, making them less, so much better post-treatment with a good endocrinologist on board in the hospital. So opsoclonus myoclonus is a syndrome. It could be metabolic, it could be infectious, it could be endocrinological as well. Okay. So another thing, don't miss on Wilson's disease. So Wilson's disease is a differential diagnosis, is a respectable differential diagnosis for any movement disorder presenting before the age of 50. It's almost always not the right answer, but it's a good differential. More classically, they present with this wing beating tremor, but also very common is dystonia. But they can present with chorea, ataxia, myoclonus. They can present with anything. So this is a case of mine with a very unusual presentation, a galloping tongue syndrome. You could see a little bit of it. I'll show you. I thought she was just doing it, but it's involuntary, actually. Hindsight, look at her face, has a little bit of a rhizus sardonicus. I didn't see it because I was just fascinated with the tongue. I didn't see what was right in front of me. So this was her presentation for Wilson's disease, a galloping tongue syndrome. As editor-in-chief of a movement disorder journal, Parkinsonism and Related Disorders, I get these presentations submissions from all over the world. And I got one case, which I'm not sure if I rejected or accepted, but had a galloping tongue syndrome like this from ALS. So just for you to know. Yeah, she had a little bit of rhizus sardonicus. She has a galloping tongue syndrome, and turns out having Wilson's. This is the more common presentation, the one in the middle, very dystonic, and the face is clearly a rhizus sardonicus face. So when you decopperize, there might be initial worsening before improvement, so don't chicken out. A lot of dystonia. There's your rhizus sardonicus in there. Now, if you miss it, if you miss Wilson's and the dystonia sets in, they develop contractures, and this is the result. This is the third image. It's not a still, it's actually moving, except that he can only move. The only thing he could move is this right arm 5 degrees up or down, and then the neck side to side. It's the only thing. Everything else is contracted. And so this is when you miss Wilson's disease. This is what happens. So we don't want to miss it. This guy has the world's most intelligent wheelchair, where all the controls are in that backrest there, and depending on the pressure as he moves his head, it can move to the side, backwards, or forwards, things like that. Okay, what is my next one? I want you to recognize, there are some clinical patterns that when you recognize, it makes your job a little bit easier. So it's always nice to kind of know about these. So one is tardive chorea. They're often, almost always, orobuccolingual. They have the bonbon sign because of the tongue dyskinesias, tongue protrusion, another one, but a lot of orobuccolingual dyskinesias. This is obviously a more severe case with limb choreas as well. And sometimes you'll get a bonus of blepharospasm that goes along with it. But the clue here really is that there is an exposure to a dopamine receptor blocking agent, usually an antipsychotic, sometimes an antiemetic, and orobuccolingual dyskinesia. And so you want to make sure you recognize this. And then tardive dystonia is the second most common tardive presentation. Chorea is the first, dystonia is the second, but dystonia is more disabling. Almost always, when they have tardive dystonia, again, a dopamine receptor blocking agent exposure, it's retrocolic or opistotonic. Okay, so almost always, when you see a presentation like this, the first question you ask is, what are you taking? And it usually will give you the answer there. So this is another case, a more profound retrocollis, and with this upward tonic deviation in the eyes, oculogyric crisis. Okay, oculogyric crisis is a more classical description of a classic disorder that we hardly see anymore, post-encephalitic Parkinsonism. But you'll see a retrocollis, you can see the oculogyric crisis there. Look at the drug, see if you can get rid of it. If not, you have VMA2 inhibitors, valbenazine, tetrabenazine, deutetrabenazine, that are really good. The most common etiology of cervical dystonia, though, is idiopathic, like this lady here. They're often torticolic. They could be enterocolic, retrocolic, but often torticollis with maybe a shoulder elevation, more common in women, usually in their 4th and 5th decade of life. Nothing else is abnormal in your neurological exam. No other symptoms except for maybe pain in the posterior neck. When you do that, there's really no need for a workup. It's idiopathic cervical dystonia, botulinum toxin is the drug of choice. When you have Parkinsonism and enterocollis, however, then MSA would be your kind of should be your working diagnosis. Okay, but obviously anything is possible for any condition, almost. So this is in my collection in my journal. So this is oculogyric crisis in a PLA2G6 variant. So PLA2G6 is mutations can present with, I think the 3 most common presentation would be NBIA, so neuroferritinopathy. They can present with dystonia, Parkinsonism. They can present with neuroaxonal dystrophy as well. So very varied spectrum of presentation. But obviously, all I'm saying is that, and the clue here would be there is no drug exposure, so you can't really blame tardive. And this one, KMT2B, it's DYT28 now. DYT28 is from KMT2B variant, presenting with opisthotonus. So this is a autosomal dominant generalized dystonia, and so any generalized dystonia usually presents first with dystonia in one body part, usually the lower extremities in children, and then spreads slowly over time to become generalized like this. Usually they present before the age 10 for KMT2B, as with most generalized inherited dystonias, and then spread over time. They can have intellectual disability, psychomotor retardation, short stature, although he isn't so short. So now, I show this because KMT2B stumps clinicians every now and again. They don't often get this because there is no family history, and so you wouldn't think of getting a whole exome sequencing or even a KMT2B panel. The reason, this is autosomal dominant, so there should be a family history, but there isn't. Because the majority, 80% of KMT2B mutations are de novos. Less than 20% are inherited. And so only in 1 in 5 you'll get a family history. In the 4 out of the 5 you won't. So you have a generalized dystonia, nothing shows up, check KMT2B. Not that you could treat it, you still treat it like any generalized dystonia, but at least you'll have an answer. Okay. So generalized dystonia, what did we treat him with? Generalized dystonia, so anticholinergic agents, but he has a lot of intellectual disability. You can't do botulinum toxin, because it's generalized, so you can't inject the whole body. But you could do for sensitive areas of the most severe ones. If it's the neck and you want to prevent fractures, or the foot so that they can walk, or the hand so they could do something, maybe you could do that. I'll show one case of a kind of neurodegenerative progressive disorder that responded to DBS, but it's more supportive measures at this point. The success here in generalized dystonia is DRD, dopa-responsive dystonia. So this is a generalized autosomal dominant generalized dystonia presenting first in the feet, lower extremity. We just see that abnormal posturing of his left foot only when running at first, then with walking, then at rest, then progressing to other body parts, then becoming generalized. So you have a little bit of time. But the first thing you do here so almost all children presenting with lower extremity dystonia will likely generalize. Almost all adults usually will present with upper extremity or cranial or neck dystonia, craniocervical upper extremity dystonia like wrist rider's cramp. Usually they won't generalize. And you could do botulinum toxin for blepharospasm, spasm, cervical dystonia, rider's cramp. That's botulinum toxin. In children with lower extremity dystonia, you have to watch that over time because they might generalize. This not much different. How is it different from juvenile Parkinsonism? Maybe difficult to distinguish in the beginning. Okay, you can get a DAT scan. It'll be abnormal for juvenile Parkinsonism. It'll be normal for dopamine responsive dystonia. But the clue here, you have this lower extremity initial presentation in a young child. Always challenge levodopa. Always try low-dose levodopa. 25, 100, 3 times a day is good enough, and it will be a dramatic response, and you will have saved this person's life, rather than waiting until they become wheelchair-bound like that teenager I showed. Now, this one, obviously, it's a case report because it's unique. You could see, look at that abnormal foot posturing on his right foot. See? So he's a little bit older, but the dystonia is on the lower extremity, not the upper extremity, and not the face or the neck. So the clinician still did a levodopa challenge, and voila, complete dramatic change. So this is a later onset dopamine responsive dystonia. So I guess the lesson here is that you have an initial presentation of dystonia. There's no harm in trying levodopa. You only need a month or two. If it's not significant, it's not it. You could move on to whatever the next step is. Okay. These are two disorders that are kind of totally different from each other, but us neurologists, we still mix them up. So myokymia. Myokymia is really a slow, involuntary kind of a rippling of the muscle that is not, it's a fascicular contraction that is not sufficient to move a joint. So it's just like there. So like a benign fasciculation syndrome. It could be benign. It usually represents a brainstem lesion, and usually in the lower eyelid or in the side of the face. You could see a little bit of that here. See that? Just a little bit. So this is a brainstem lesion, is the source, and happens to be cysticercosis. So it doesn't really tell you, I mean, it gives you the involved parts, but not necessarily anything more than that. You could get it from neuromyotonia, recovering AIDP, for example. So there are many etiologies, but for the more severe one, the more significant one would be a brainstem lesion. Now, myarrhythmia, these are slow, rhythmic movements, usually in the eyes and asymmetrically in the face. It's very slow, 1 to 3 hertz. So very slow. This one he has a pendular motion in the eyes. You can see, and then see a little bit of that pendular thing there. See that pendular? And then coupled with the facial contraction. So you see that in Whipple's. You could see that with brainstem lesions, multiple sclerosis. See the face there? So very slow. Okay. Now, when you see stereotypic disorder movements, something that you keep moving over and over, there's one that you treat and the other one you don't. So you treat a tic if it's bothersome. So you see that very stereotypic movement, twitching of the lips, blinking of the eyes, vocalization, grunting, or 2 or 3 that just rotate. You treat that. There is an urge. There is the execution of the tic, whether it's simple or complex, whether it's motor or vocal, and then there's a temporary sense of relief, and then only for another build-up, another execution. And so you need to cut that cycle, and then depending on how severe it is, you have all the tic treatment options. The stereotypies are also very stereotypic. They can be twitch, they can be repetitive movement, but they're not bothersome. There's no urge, there's no build-up, there's no sense of relief. They can even be distracted for some time. And let me see if there's, and they are often in mental retardation state, autism spectrum disorder states. So this one has a chromosome 1 mutation, one of only 3 in the world that has this mutation. Apparently, I had to search it because I'd never heard of it. But what I know is that he has a stereotypy. And it's that just constantly doing this thing, rocking, they're not bothersome. They're just, when you leave them alone, they're just rocking like that. And then you talk to them, they stop maybe, and then they do that again when you leave them alone. You don't need to treat that. The treatment, that is assurance of the concerned parent that there's nothing really to do other than just not be worried. Okay. Let me see where I am. Be comfortable with functional movement disorders. So if anything, functional movement disorders, you have to be confident. It is not a diagnosis of exclusion. You can get all the things in the world you want. Maybe there's a purpose. Maybe you're really not sure. That's a good purpose. Or sometimes you want to at least have some confidence to the patient that you did not dismiss everything. That's a decent purpose. But for the purpose of diagnosing it, when you know what it is, it's not a good reason. Over 90% of the time, if the clinician suspects a functional neurological disorder, he or she or they are correct. And there is no reason to overly do it. And compare it to, say, Parkinson's disease, where we are sometimes confident in diagnosing Parkinson's disease. You have Parkinson's disease, sir. I'm sorry. We are correct about 60 to 70% of the time. So we have to place our confidence where it should be. Very confident. We are almost always correct. In FMD, we are sometimes correct or sometimes wrong in Parkinson's disease. So there are several clues. There are no organic findings present. If it's a twitch, you do an EMG, it's more than 50 milliseconds, so it's not really a myoclonus, it's a made-up myoclonus. The variability, the distractibility, and the entrainment are the 3 key features of functional movement disorder. And yeah, the variability, distractibility, and entrainment. And if you have the benefit of an EEG for the ones that you're really not sure, you have that pre-movement potential, the Berezhev's potential. I don't know how to pronounce it, but you have that before the movement itself. So this is a case of a functional myoclonus kind of involving the trunk. The trunk is very difficult to involve. Its representation in the homunculus is very small. And so you have predominantly a variable kind of trunk kind of thing. We have to suspect functional movement disorder in this case. And then you have sudden onset, there is a trigger, and things like that. It makes it a lot easier for us to diagnose it. And sometimes it's not, and you have to do at least maybe a spinal cord and an MRI and then show nothing, and then really that's about it. Okay, so this is another case, some positive signs. So variability. You could look at the variability of the frequency of the tremor. So sometimes it's slow, it pauses, and then sometimes the frequency of the two hands are a little different, and then look at the distractibility. So we focus on the eyes, they forget about the shaking, and then and then they'll sometimes remember in the middle, and then they'll shake again. But this one, he didn't shake at all. Then sometimes it's just plain unusual, just weird. This one has like, it wants to go in circles and backwards. When he walks forward, it goes back, it goes circular again. Sudden onset after some bad news that happened and stuff like that. So, so these are clear functional disorders. Okay, but not all that looks silly is functional, so just always be careful. This one is unfair, but I just wanted to show you that, they can have, neuroacanthocytosis can have this weird astasia-abasia-like gait, but in this case, it's a very clear organic disorder. You have orophageal dysphagia, you have chorea, you have cognitive dysfunction. So he's not really considered for functional, but I just wanted to showcase the gait. Now this one often can be mistaken because they have ciliar walks in this. This is called silly walk for levodopa-induced dyskinesias or levodopa-induced gait disorders. They can respond to visual cues, like less silly when, okay, just focus on the steps, but but there are more of these silly walks that we get. So yeah, the silly walk is coming back up, but a little bit muted with a visual cue. Okay. Last 10 minutes. Brain scan. They are our friend, okay? They are not the enemy. They are only the enemy if you don't know what you're looking at. But they can be helpful potentially in kind of preventing this vicious cycle of uneasiness. So again, Wilson's disease, so focused on a few things here. Do not ever miss Wilson's disease. So sometimes the scan can help. You see here, so this is in the mesencephalon, the midbrain axial mesencephalon. You have the giant panda sign, the eyes of the panda, ears of the panda, so like that. You could imagine it, right? Kind of. And then the pons, you could have the baby panda sign, the baby panda. And then here, another one, in the thalamus, the split thalamus sign. So you see the split of the thalamus because of that line there, hyperintensity. So you have a split thalamus sign. And then this one, you have the bright claustrum sign. So when you see something like this, everything lighting up, the basal ganglia, bright claustrum sign. Okay. This one, if you miss, it's not really the end of the world, but sometimes you give early closure. Exactly. You get early closure to the patient, to the family. So earlier on, you have just hyperintensity of the corpus striatum, a little bit more intermediate. In the more classical form, in the later stage, you'll have the cortical ribboning. So CJD, classical CJD, you have a little bit of the pulvinar sign, a hockey stick sign, but it's more predominant in the variant, the mad cow disease, the variant CJD. So you could see the hockey stick, the pulvinar sign, a bit more common there. Okay, what is the phenomenology? Mouth wide open, can't close the mouth. Look at the face, rhizus sardonicus. It's just a phenomenon, not the diagnosis. So, well, that's the diagnosis, but it's more dystonia. So she has generalized dystonia, a lot of oromandibular dystonia, but axial dystonia, limb dystonia, right? Okay, so you can't tell where this is going to be coming from. Had this for a long time, gradual, chronic, progressive, over a decade of this. Look at this. Could hardly walk, and that mouth wide open. If she didn't have this severe dystonia of the limb, the natural presentation of these patients would be with a mouth open like that, and they're doing this because they're trying to close it. And in effect, it looks like the praying mantis, a praying mantis sign. She doesn't have the praying mantis because she has this axial dystonia that prevents her from doing this thing. But when you see that or a praying mantis sign over 2 decades, you think of, okay, I'll give you a clue, and it's in the brain scan. So you have the eye of the tiger sign. So this is a neuroferritinopathy, PCAN. Now look at what happened here. Not cure, but significantly more comfortable. So the clinicians thought that for palliative care, compassionate use, they justified placing deep brain stimulation surgery, DBS, in the globus pallidus. And it improved is the key word, the dystonia. So, in her case. So a little bit better quality of life. Okay. This one, also with dystonia. Generalized over the years, intellectual disability, some behavioral. So again, a very syndromic kind of disorder. And then you get this, and you have this in the mesencephalon, you have the hyperintensity of the cerebral peduncle, and that hypointensity in the central, it's giving it the halo sign. So, BPAN. And this one, levodopa, improved the dystonia a little bit. It's just a little report. I think I rejected this case. Okay. I'm sorry. So, yeah, so the eye of the tiger sign is the PCAN. The medial medullary sign, MPAN, okay? And then you have that halo sign, BPAN. At least if you see this, if you stumble into these pictures and you have a generalized dystonia presenting for a long time, then you could give kind of some closure. And at least I showed you, you never give up. Sometimes you can do DBS, levodopa, or some other medication to just make them a little comfortable. Okay. These ones are all different diagnoses, but they have the same kind of theme, a picture. What do you see? Anything striking at you? Here, hyperintensity here, hyperintensity here. MCP sign. The middle cerebral peduncle has a hyperintensity, and you could see that in many conditions, okay? Friedreich's Fragile X tremor ataxia syndrome is one of them. That's the kind of classical presentation. You can see it in MSA. You can see it in NMO. You can see it in PML. You can see it in PRESS. So look at all these history in primary CNS lymphoma. So many things, but when you see this, it narrows it down to a few, but but they can be potentially helpful. Okay, what about this? Sometimes it's hard to see it on MRI. You could see like hypointensity and hyperintensity in some cuts and stuff like that. But sometimes the CAT scan is very helpful. So this is a FARS syndrome, right? So hyperparathyroidism, hypoparathyroidism, pseudo-hyperparathyroidism, all these parathyroid kind of things can do that. And they can present with dystonia, they can present with tremor, less chorea, sometimes Parkinsonism. So you have that. Okay, what else? Okay, so sometimes they say global cerebellar atrophy, clinical correlation required. What are you going to do with that? So I'll give you some clues. Thinning, premature graying and thinning of the hair. How about that? None yet? Nothing. What about periungual warts? Okay. Last. How about telangiectasia in the eyes? So ataxia telangiectasia syndrome with this case. So this one, I actually don't, I'm sorry? Okay, so presents with hand dystonia, and some dystonic tremor, but a lot of ataxia. Later, I'm sorry, I'm actually I don't know the diagnosis of this. I don't have my cheat sheet, but maybe it'll come to me. So a lot of ataxia later on, but presenting with hand dystonia and gait ataxia. Has a brother, I think he has a brother, also presenting at age 10 with some ataxia and then hand dystonia. So they have a very similar presentation. They have their parents are third cousins, so consanguineous parents. And then there's global atrophy, pretty much. So ataxia, a lot of ataxia is really, Friedreich's ataxia should be your number one, but there isn't much global cerebellar atrophy in Friedreich's ataxia. So almost all the other autosomal recessive ataxias, so autosomal recessive consanguineous parents could do this. I think I remember this. This is autosomal recessive due to coenzyme QE deficiency. Coenzyme Q deficiency, Q10. Okay, we're done.